Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 433 of our pharmacotherapy series, which majors in breast cancer. The first case reads, GMP is a 42-year-old woman with no personal history of breast cancer. She has a cousin who was diagnosed with breast cancer at the age of 65 years. GMP is in her doctor's office today to discuss routine breast cancer screening. So my question to you is, based on GMP's personal and family history, would GMP be considered an average risk or high-risk patient, and what modalities of screening are recommended for average risk and high-risk patients? The guidelines for cancer screening for breast cancer were recently updated in 2015 and led to major changes in the recommended screening modalities and intervals of obtainment for women of average risk of developing breast cancer. For the average risk patient, screening involves a mammogram and a breast self-examination, if the woman chooses to do so. Although the risk of breast cancer is low in one's 20s, breast self-examination allows a woman to become more familiar with her body and better able to discern changes as she ages. Clinical breast examinations have long been part of the screening guidelines, but with the new changes in recommendations, this component of screening has been removed due to a lack of benefit of detecting breast cancer in a woman with average risk. Screening mammography has been the gold standard for breast cancer for many decades. With the newer recommendations, a change has occurred as to when to start mammograms and the intervals in which they should be obtained. In the older recommendations, mammography was recommended annually starting at the age of 40. In the newer guidelines, women of average risk should have the opportunity to begin annual mammograms between the ages of 40 to 44, and then annual mammograms should commence at the age of 45 through. Once a woman turns, she should transition to biennial screening or have the opportunity to continue annual screening. The guidelines also recommend for women to continue screening mammograms as long as their overall health is good and their life expectancy is 10 or more years. For many years, there has been controversy regarding the utility of mammography and when screening should begin, that is at 40 or 50 years of age. This controversy has stemmed from recommendations by the USPSTF. Their newest recommendations state that the decision to start screening mammograms before the age of 50 should be an individual decision. Women may choose to begin biennial screening between the ages of 40 to 49, but that this may lead to more false positive results and unnecessary biopsies. The guidelines state that the largest benefit for screening mammograms occur in women ages 50 to 74, and there are insufficient data to support the utility of annual mammograms in women greater than or equal to the age of 75. While these screening recommendations can be confusing, the controversy that has stemmed from the changes has heightened the awareness to the general public of the importance of breast cancer screening. GMP has no first-degree relatives with breast cancer or other family members affected by early breast cancer. GMP is an average-risk patient, and she should start standard screening modalities and intervals of testing with annual mammograms and clinical breast examinations. She may also decide to do breast self-examinations. Individuals considered high risk include those that a. have a known BRCA gene mutation, b. are untested for the BRCA gene mutation but have a first-degree relative with a BRCA mutation, c. have a lifetime risk of experiencing breast cancer of approximately 20% to 25% or more based on risk estimation models, or d. have a strong family history of breast cancer. Screening with breast magnetic resonance imaging is recommended in high-risk individuals. Annual mammography and breast MRIs should be initiated starting at the age of 30 years in this population. An MRI allows a radiologist to see a contrasted view of the breast and is more sensitive to detecting breast cancer. In addition, breast tissue in younger patients can be denser due to higher levels of estrogen, making mammography less sensitive. The next question reads: GMP works at her local hospital as a nurse and is volunteering this year at their breast cancer awareness seminar that is offered by her hospital. She was asked to prepare a talk for the event about breast cancer awareness. She wants to discuss breast cancer prevention. So my question to you reads: what are the common modalities of breast cancer prevention that GMP should address, and what chemopreventive agents should she include? Prevention is key with any cancer. Women who are considered high risk for breast cancer may decide to undergo prophylactic mastectomy with reconstruction as an alternative to living with the prospect that they may develop breast cancer in their life. This modality of prevention is very successful, but does not completely eliminate the risk for developing breast cancer. In addition, prophylactic oophorectomy may also be completed to remove the largest source of estrogen in a premenopausal patient. This does not, however, eliminate the risk completely from developing breast cancer. Chemoprevention is also another option. Two agents approved for prevention are tamoxifen and raloxifene. Both are selective estrogen receptor modulators, abbreviated as SUMS. The Breast Cancer Prevention Trial, or P1 trial, was conducted in more than 13,000 high-risk women, who were randomly assigned into three groups: those older than 60 years, 35 to 59 years of age with an increased risk of breast cancer based on a score of at least 1.66 as determined by the Gale risk model, or older than 35 years with a history of LCIS, a risk factor for developing invasive breast cancer. Women received tamoxifen 20 mg daily or placebo for 5 years of therapy. Tamoxifen significantly decreased the risk of developing breast cancer, with a p-value less than 0.00001. In addition, this study illustrated toxicities associated with tamoxifen therapy, especially in women older than 50 years of age. In those patients, A higher risk of deep vein thrombosis, stroke, pulmonary embolism, and endometrial cancers was identified. Raloxifene was also approved for chemoprevention in breast cancer. This originated from observations made in osteoporosis studies with raloxifene, where patients who had received raloxifene therapy had a decreased risk of breast cancer. With this information, a large randomized chemoprevention trial of more than 19,000 postmenopausal women was conducted evaluating the use of raloxifene 60 mg daily compared to tamoxifen 20 mg daily for 5 years. There was no difference in the number of invasive breast cancers diagnosed in the two treatment arms. Relative risk, 1.02. With a 95% confidence interval of 0.82 to 1.28. Interestingly, more non-invasive breast cancers were identified in the raloxifene group, that is 80 cases, compared with tamoxifen, that is 57 cases. However, the clinical significance of this difference is unknown. The tamoxifen arm reported more hot flashes and endometrial cancer, and the raloxifene arm demonstrated fewer thromboembolic events and cataracts but more musculoskeletal problems and weight gain. Based on the results of this trial, raloxifene received an indication for chemoprevention in high-risk women. The aromatase inhibitors, exemestane and anastrozole, have been studied in the chemopreventive setting in postmenopausal patients, in the NCIC-CTG MAP3 trial and IBIS-2 trial, respectively. Although both trials demonstrated reductions in breast cancer incidences, neither agent has been compared with tamoxifen or raloxifene, and so they are not approved for use as a preventive therapy at this time. GMP should include information on prophylactic mastectomy and both tamoxifen, for pre- and postmenopausal patients, and raloxifene, in only postmenopausal patients. In her talk for women with a high risk of breast cancer, but not exemestane or anastrozole. The next case reads, BMW, a 55-year-old woman, is found to have a 2.2 cm mass in the upper, outer quadrant of her left breast during a routine screening mammogram. The rest of her physical examination is unremarkable, and she has no complaints. All laboratory values, including the complete blood count and liver function tests, are within normal limits. A chest X-ray is negative. BMW reports that she had her first menstrual cycle at the age of 10 years and has had regular periods since that time. She is married but has never been pregnant. So my question to you is, what are BMW's risk factors for developing breast cancer? Many different risk factors have been identified to be associated with the development of breast cancer. However, in greater than 50% of patients, there are no identifiable risk factors beyond increased age and female gender. One's risk increases with each decade of life, and the median age of diagnosis is between 60 and 65 years of age. If the patient has had a previous history of breast cancer or atypical hyperplasia from previous breast biopsies, this increases her risk of developing breast cancer. Breast cancer is a hormonally mediated disease, and many factors are associated with hormonal influences. Early menarche, generally defined as younger than 12 years of age, and late menopause, generally defined as older than 55 years of age, expose a woman to more estrogen throughout her lifetime, increasing her risk, relative risk, RR, equal to 1.5 for age 55 for late menopause. Based on the results of the Women's Health Initiative, the use of hormone replacement therapy was shown to increase one's risk of breast cancer. Nulliparity, or having children after the age of 30 years, has been associated with an increased risk, that is RR increased up to 3.5. Oral contraceptives have long been thought to increase the risk of breast cancer. Earlier forms of oral contraceptives contained much higher doses of estrogen compared with products today. The dose of estrogens in those products was thought to increase a woman's risk of developing breast cancer. However, a meta-analysis demonstrated no difference in risk no matter the dose of estrogen in the oral contraceptives. Hereditary breast cancers, one or more first-degree relatives with the disease, only account for approximately 10% of breast cancer cases. However, these individuals have the highest risk of developing breast cancer. BMW has risk factors that increase her risk of developing breast cancer. BMW started menses early at the age of 10 years and therefore has been exposed longer to estrogen, and she does not have any children. She is also 55 years of age, and the risk of breast cancer increases with each decade of life. Therefore, all of these are considered risk factors for BMW. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 434.